Hi there. My name is Sam Skulsky. I'd like to clarify I am a medical student from the University of Alberta, and it's a great honor to be here to present today. I'm here to talk to you about the utility of the Edmonton Obesity Staging System in predicting post-operative complications after bariatric surgery. And as a medical student, you can imagine I don't have any conflicts of interest to disclose. So bariatric surgery is a proven modality for managing patients with obesity, as you all well know. And over time, the complications have been decreasing, but they're ever present, and when they occur, can be very serious. We've seen, in the literature, they've looked at multiple factors to try to identify and predict postoperative complications, looking at the procedure, approach, patient factors as well. And there's various findings on that. One of the ones I want to talk about is BMI. We all know, like, numerically equivalent BMIs aren't always the same. They inherently does not assess functionality, quality of life. And actually, there's a bit of research suggesting that patients who are overweight or moderately obese actually have some survival advantage when they undergo surgery compared to morbidly obese and those of normal weight. So it's not quite clear. And to that end, there is a tool that we developed that was developed by Sharma and Kushner as an adjunct to BMI that's used to evaluate overall mortality risk in patients with obesity. To clarify, it doesn't matter if they're undergoing surgery, this is just patients with obesity in general. And the research actually has shown that it's independently predict increased mortality. So I'll just go over the staging system as we use it. It's graded from 0 to 4, increasing in score as you, with the concomitants of comorbidities. And the rating is completely independent of BMI. So I'll go through each of them really quickly. You can see stage 0 patient would be someone who has obesity but has no obesity-related comorbidities or psychiatric symptoms or functional limitations. Stage 1 being the appearance of subclinical risk factors, so your borderline hypertension, impaired fasting glucose, transaminitis and whatnot. And Stage 2 is where you typically get the patients that would actually qualify for bariatric surgery when they have a BMI greater than 35. So it's patients with hypertension or type 2 diabetes, hypothyroidism, sleep apnea, or the psychological symptoms accompanying obesity. Stage 3 being that with or patients who have signs of end organ damage, so your diabetic retinopathy, nephropathy, evidence of past MI. And then your stage 4 are patients who really aren't doing that well, potential end stage. So that's a bit of an overview. This is just a quick reference to previous, the research that I had mentioned previously. When applying the EOSS score to the NHANES, the National Health and Human Nutrition Examination Survey, the EOSS actually, you can see with the Kaplan-Meier survival curves that it actually nicely stratifies patients with their overall survival. In comparison, BMI didn't do as good a job of delineating the overall mortality. So that's patients overall with obesity. So our question and what we wanted to address in our research is whether or not the EOSS predicts complications or mortality after bariatric surgery. And there is some suggestions that it may have this utility in the research. Chipetta et al., I believe in 2014, found that there was a commensurate increase in complications with increase in EOSS score. However, they didn't do a full statistical analysis, and they only looked at 30-day post-operative complications, and they didn't delineate between major and minor. So we wanted to see if EOSS independently predicts 1-year major complications after Roux-en-Y gastric bypass. So what we conducted a retrospective chart review of patients greater than 18 years receiving primary Roux-en-Y gastric bypass between the years of 2009-2015 at the Royal Alexandra Hospital in Edmonton. Collected patient demographics, EOSS score, their preoperative BMI, patient comorbidities, as well as we followed them for a year post-operatively for major complications. The EOSS score was assigned by experienced clinicians within the bariatric clinic. There were usually 2, and we looked for agreements in score. We defined our major complications as Clavien-Dinto score greater than 3A, and we performed a multivariable logistic regression analysis to calculate the odds ratio of major complications in patients with EOSS 3, or greater or equal to 3, versus those with USS scores of 0, 1, and 2. This is a brief summary of the characteristics of the patients. We had 378 in total. You can see their mean ages and preoperative BMIs, and this is the distribution of the comorbidities that were collected. And this is the characteristics of the study participants by USS score. As you can see, if you look at USS 2, they form the predominant cohort, and this may reflect a preoperative selection bias because these patients are inherently a little healthier than your EOSS 3s, and again, you have to qualify and have comorbidities with a BMI greater than 35 compared to the EOSS 0s and 1s. And you can see there is an increase in complication percentage. Yes, the EOSS 1 does have a 7% complication rate, but if we look at the one more slide further, this is just the overview of the complications that we had. That you can see for major complications, anastomotic stricture and leaks and bleeding were our most common complications, followed after by incisional hernias. And the next slide shows, so on our multivariable logistic regression analysis, the adjusted odds ratios for age, preoperative BMI, and sex did not predict increased risk of postoperative complications. We found a near 3-fold increase odds of major postoperative complications for patients with EOSS of 3. So, in conclusion, the EOSS helps to determine risk of major complications after Roux-en-Y, and given its overall simplicity, you can almost think of it's analogous to like the ASA or the New York Heart Association's classification system for congestive heart failure. It may have utility as well in communicating to patients their overall risk. Although the patients with higher EOSS scores, like the EOSS 3, when they have end organ damage, may benefit from bariatric surgery, they inherently have higher postoperative risk, and we must take that into consideration. There are a few limitations with the study. We looked only in our full analysis the Roux-en-Y gastric bypass patients. There is, of course, the EOSS 2 bias. And we didn't have many EOSS 4 patients. They're not commonly operated on as far as I understand. So we didn't actually get to look through the entire scoring system. And I'd just like to say before questions as well, we are actually looking at moving this forward to the MBSA QIP database, and the results that we have found are pretty encouraging. Thank you.